Alright, so we're back and we are going to do another topic, okay? So we're gonna have to do other ILDs, okay, because that's important as well. So let's do that. So we are going to reset this. Reset and also change deck. Okay. Okay. And then, all right, here we go. Symptoms of interstitial lung disease. So there's two things. Well, there's Disney and there's like non-critical cough. I mean, yeah, this is pretty done. Non-granulomatous. So we're looking at anti-GBM disease, good pasture. Looking at pulmonary alveolar proteinosis. Okay. You're also looking at idiopathic pulmonary fibrosis, and you're also looking at a cough badge, so cryptogenic organizing pneumonia. Okay, so let us do that. Okay, so another name for anti-GBM, that's your good pasture syndrome, is characterized by dash antibodies. So it's like, what are we looking at? There's like IgG antibodies, okay? They're against the type 4 of collagen. Like I said, these are number 4. There's a number 4. All right, good. Good. Try that again. So anti-GBM antibodies target the base member of what two locations? So you're looking at a renal and also pulmonary alveoli. I like that. I like that. Okay. Demographics of anti-GBM antibody disease. What are the demographics? They're males and they're less than 30 years old. Okay. Males less than 30 years of age. That's amazing. Okay. And what else? Okay, so we got that. We got males less than 30 years of age. Okay, so let's do that. What increases the risk of pulmonary disease and anti-GBM antibody disease? So smoking can increase. So looking at smoking, that can increase. So lab finding BMP anti-GBM antibody disease. Increasing creatinine. Okay, so creatinine is increased here. Okay. Workup here is you want to do creatinine. You want to do urine analysis. You want to do chest X-ray. You also want to do biopsy. Chest X-ray, biopsy, urine analysis, creatinine. All right. Now, what kind of renal injuries caused by anti-GBM antibody disease? Name 3 significant findings on urine analysis. Okay. So there's proliferative glomerulonephritis, hematuria, dysmorphic RBCs, and RBC casts. Okay. And proliferative glomerulonephritis. Okay. That's what you get. Okay. Then chest X-ray findings anti-GBM antibody disease. So you have bilateral pulmonary infiltrates. So yeah, that's what you have. Bilateral pulmonary. Oh yeah, look at that. There is bilateral pulmonary infiltrates. Yeah, that is okay. What is the definitive diagnostic test for anti-GBM antibody disease? What are significant findings on this test? So renal biopsy. Have a linear deposition of IgG. Okay. Management of anti-GBM antibody disease is you're looking at plasmapheresis, okay, your systemic glucocorticoids, and immunosuppressants. Okay. So plasmapheresis, okay, systemic glucocorticoids and immunosuppressants. Okay. Yeah. All right. So describe pathogenesis of pulmonary alveolar. What is a pathogen? So there's accumulation of past positive phospholipids and proteins. Okay. There's accumulation of all those snacks. Okay. So what happens? What it says middle-aged men smoking. Lab finding is GM-CSF, really? Granola, mints, chips, soda, fries. That's what you get. Okay. Chest X-ray. You have a bat wing pattern. I'll remember bat wing. Okay. Was definitive diagnosis of alveolar proteinosis. What are significant findings on this test? So BAL. Oh yeah, and then you'll find past positive material. Yeah, sure. Okay. Then pulmonary alveolar proteinosis management is just whole lung lavage. Okay. And then what is the most common type? Idiopathic interstitial pneumonia is idiopathic pulmonary fibrosis. Yeah. Or usual intermediate premium. Okay. Now, idiopathic is associated with pathological finding of usual interstitial pneumonia. Okay. That's what you get. Usual interstitial pneumonia. Okay. Demographics are males smoking 50 to 70. Okay. Physical exam finding interstitial lung disease. I mean, I know clubbing and I also know crackles. No, what was the other thing? I always forget this. Yeah, I guess crackles, yeah. Yeah, so, you get that. Then PFT pattern, well, is it restrictive? Yeah, it is restrictive. And then DLC will be decreased, okay. Restrictive, yeah. And ABG findings. What ABG findings we get? Increased A grading. Really? I didn't know this. Wow. Okay, that's interesting. An ABG. We've got idiopathic pulmonary fibrosis. I guess like lung biopsy, obviously chest X-ray, and then an ABG, since they mentioned it. Oh, high resolution CT. Do you have that here? CT. yeah. All right. I'm good, dude. The findings are reticular opacities and lower lung zones, lowered window. Nice. Okay. CT findings are bibasilar reticular passive honeycombing attraction bronchiectasis. Wow. Okay. Reticular opacities with honeycombing, so it's like bronchiectasis findings. Management is, I guess, oxygen and lung transplant. Wow, they're actually doing it. Okay. And then what non-infectious lung disease is a form of pneumonia with no known cause? It's a form of pneumonia with no known cause. I don't know. That's croup. That's a non-infectious lung disease with no known cause. Croup or COP, cryptogenic organizing pneumonia. Okay. Chief complaints here are fever, malaise, non-for the COP, dyspnea. Workup is biopsy, obviously, and then chest X-ray. Okay. Chest X-ray findings are bilateral ground glass opacity. Okay. Diagnosis for this one is biopsy. So the findings are features of BOOP, which is bronchiolitis obliterans organizing pneumonia. Okay. Management is, I think, systemic glucocorticoid. Okay. What is it? It's increased. Why? Because fibrosis impairs diffusions and is decreasing the OCL. Okay. What two locations? So we know one is the lungs, one is the kidney. Okay, good. Now 4. So you have Goodpasture syndrome. You have COP. You have idiopathic fibrosis, and what's the other one? Oh, wait, there's another one. Yeah, pulmonary protein alveolus. Yeah. The disease is demographics are. What am I looking at? 30. Yeah, nice. Lab finding. What did I remember about this? Creatine. Crazy. Yeah. This is an anti-GBM antibody disease. Anti-GBM antibody disease. Okay. Increase the risk for pulmonary disease. Okay, so that is what increases the risk? Smoking cigarettes, right? So rise by IgG antibodies against what was it against? It was collagen type 4. A couple of anti-G antibody diseases. Well, you want to do biopsy for sure, chest X-ray, urine analysis, and what else do you want? It's creatine with also urine analysis. Yes. All right. Chest X-ray findings of anti-GBM antibody disease. Oh, what did I remember reading? And I don't even remember. Bilateral pulmonary infiltrates. That's not really good enough. Oh yeah, I guess so. Alright. Demographics of pulmonary alveolar proteinosis. What are the demographics of pulmonary alveolar proteinosis? I'm not sure. Yeah, what could it be? We're looking at I don't know. What did I remember about this? It was a male smoking 40. Man, middle aged, yeah, whatever. Management of this one is whole lung lavage. It was caused by anti-G antibody disease. Named three significant findings on urine analysis. So, injury is caused by anti-GBM antibody disease. Damn, like, what kind of renal injury? That was nephritis. So hematuria, RBC cast, and then dysmorphic RBC is nice. Now, different diagnostic test is in the position of IgG. Okay, that's what he do, huh? In the position of IgG, okay. Then management of anti-GBM antibody disease is your I don't know. What would be the management? I don't know. What did I do? What did I do for this? Glucocorticoid? I don't even remember. Plasmapheresis, glucocorticoid, immunosuppressants. Okay. This was a pathological finding of. What was a pathological finding? Usual interstitial. That's you just call it that. UIP. Okay. Then it says a pulmonary alveolar proteinosis. Pathogenesis of this is I don't remember. This is pulmonary alveolar proteinosis. I don't know actually. Pulmonary alveolar proteinosis. Good point. We have the proteinosis. So you could have other stuff. I don't remember what it could be. Pattern pulmonary alveolar proteinosis. I don't know. Yeah, there's like P proteins and stuff like that, but I don't know what other could be. Patho. What do they remember? There's like these like proteins, past positive proteins that accumulate. That's all. Yeah. The diagnosis is obviously going to be biopsy. No, I think BL, right? And then positive, yeah. Hepatic interstitial pneumonia. Most common type of idiopathic interstitial pneumonia. What are we looking at? Pneumonia is your idiopathic pulmonary fibrosis, and then ABG findings. There's an increased AA gradient. Chest X-ray will show you past positive materials and lungs. So bad wing. Past positive material. That's really no anti-GM CSF. Okay. Idiopathic pulmonary fibrosis. What is the chest X-ray finding? Reticular opacities, lower lung zones. Okay, reticular opacities, lower lung zones. Now, a CT finding idiopathic pulmonary fibrosis is, what could it be? Let me think. What are we looking at? So, CT finding idiopathic pulmonary fibrosis. So it'll be like bibacillar reticular opacities with honeycombing, similar to what you have in bronchiectasis with traction bronchiectasis. Okay, stuff like that. And then workup would be for cryptogenic, obviously biopsy and also chest X-ray. With non-infectious, that's cryptogenic organizing pneumonia. Demographic of idiopathic pulmonary fibrosis is like a man 50 to 70 smoking. Chest X-ray finding cryptogenic organizing pneumonia is bilateral ground glass opacity. Hepatic pulmonary fibrosis management is what is the management? What was it? It was, I know lung transplant was one of them. Immunosuppressants? No, oxygen and lung transplant, but that was a little, you could do it good. Complaints, I mean, you will have malaise, fever, dizzy, non-productive cough, that kind of stuff. Workup idiopathic pulmonary fibrosis will show. What did I do? I mean, lung biopsy for sure, chest X-ray for sure, CT, ABG also. Oh, there's no biopsy. Nowhere is there biopsy. Okay. Diagnostic test for this one is, well, biopsy was test features of bronchial litterans, organizing pneumonia. Idiopathic pulmonary fibrosis, what is the AA gradient increase? Why? Because fibrosis impairs diffusion, here's DOCO. Glucocorticoid, and then chest X-ray findings, anti-GBM antibody disease. Chest X-ray findings are, what did I see? Bilateral peripheral pulmonary infiltrates, and then for anti-GBM antibody disease is, what is it? Definitive diagnosis test for anti-GBM antibody disease. What did I remember? Biopsy for sure. What did you see? I don't remember what I saw. Linear deposition of IgG. Pulmonary fibrosis disease associated with pathological finding of usual interstitial pneumonia. Management is immunosuppressive, glucocorticoid, and plasmapheresis. Nice. Okay. Lab finding pulmonary alveolar proteinosis. Okay. Okay. Pulmonary alveolar proteinosis is. Let me think. So, pulmonary alveolar proteinosis. What was it? What was a lab finding? GMCSF, yes. Chest X-ray PAP was, what was in chest X-ray? Let me think. What did I see? Bat wing appearance. Chest X-ray finding idiopathic pulmonary fibrosis. Chest X-ray showed lower lung reticular capacities. And then the definitive diagnosis test for anti-GBM is your biopsy. Significant finding on this test is linear deposition of IgG. Finally, that was good.